Good evening, everyone. So my next video is on the topic oral anticoagulants. In previous video, I've discussed with you about the parenteral anticoagulants. Now in this video, I will discuss with you about the oral anticoagulants. And before I start my video, I want to request you, if you like this video and if it is useful and helpful to you, kindly subscribe to my YouTube channel, that is Dr. Nitika Pharmacology Discussion. Now I'm going to discuss with you oral anticoagulants. So classification of oral anticoagulants is by the coumarin derivatives like bis hydroxycoumarin, which is dicumarol, warfarin sodium, and acinocumarol and ethyl biscumar acetate. Enantione derivative is phenandione. Direct factor 10A inhibitor is the rivaroxaban. Direct thrombin inhibitor, oral thrombin inhibitor is the dabigatran and zimalogatran. So these are the drugs which are oral anticoagulants. So first of all, warfarin is the synthetic derivative of coumarin, a chemical found naturally in plants like woodruff. This it is present chemical. It is present naturally in the plants like woodruff, coumarin, and it is the synthetic derivative of coumarin, that is warfarin. It acts as the anticoagulant only in vivo. In vivo means only in the human beings, in the living medium, living human beings, it will be effective as the anticoagulant. Warfarin inhibits the factor, if warfarin inhibits the vitamin K dependent synthesis of the biologically active forms of the calcium dependent clotting factors like factor 2, 7, and 9 and 10. Means they will inhibit the vitamin K epoxide reductase enzyme, which is responsible for the activation of the clotting factors. So it will inhibit this, and the mechanism of the process of formation of the activation of the clotting factors will be inhibited. So it inhibits the enzyme vitamin K epoxide reductase and interfere with the regeneration of active hydroquinone. Means vitamin K epoxide gets converted to vitamin K hydroquinone by the action of vitamin K epoxide reductase, and it will inhibit this enzyme. And when this vitamin K hydroquinone is not formed, it is act as the cofactor for the enzyme gamma glutamyl carboxylase, which is responsible for carboxylation of the clotting factors. So it will act as the cofactor. This hydroquinone, vitamin K hydroquinone, it will not be formed. So it will lead to inactivation of gamma glutamyl carboxylase enzyme. So carboxylation of these clotting factors will not occur, and thus it has the anticoagulant effect. Its effect develops gradually over 1 to 3 days. Heparin was having the instant onset of action. Its action, it develops gradually over 1 to 3 days. Like this, in this see, this is vitamin K epoxide. This is reduced by the vitamin K epoxide reductase to vitamin K hydroquinone, and it acts as the cofactor for the gamma glutamyl carboxylase enzyme to convert the descarboxyprothrombin into the prothrombin, which are factor 2, 7, and 9 and 10. So this carboxylation process doesn't take place. So this will lead to inhibition of the activation of the clotting factors. So pharmacokinetics is, it is a mixture of R and S enantiomers. S form is more potent and metabolized by microsomal enzymes and partial glucuronidation and excreted in the urine. Rapidly and completely absorbed, 99% protein bound. It is 99% protein bound and it is rapidly and completely absorbed. Crosses the placenta, and when it crosses the placenta, it can lead to fetal warfarin syndrome, and it can also be excreted in the milk. It is teratogenic. It can lead to fetal warfarin syndrome when it crosses the placenta. Dose has to be regulated by measuring the prothrombin time or international normalized ratio. So prothrombin time is historically a most reliable and relied upon clinical test. However, the reliability of the result of the prothrombin times is influenced adversely by the variability in the sensibility of the thromboplastin reagents used by different laboratories. This problem has been markedly reduced by reporting the prothrombin time ratio as an international normalized ratio given by WHO. So this is the mathematical correction of the prothrombin ratio for differences in the sensitivity of the thromboplastin reagents. Allows for comparison of results between lab standardized reporting of the prothrombin time. The factors increasing the warfarin effect, like just the vitamin K, it is the antagonist of the warfarin. So the availability of the vitamin K is reduced in debility, malnutrition, malabsorption, prolonged antibiotic therapy. So the availability of vitamin K is reduced in the liver. So the action will be enhanced of the warfarin. In liver disease, there is synthesis of clotting factors is deficient. So it will increase the action of the warfarin. Hypothyroidism, clotting factors are degraded faster. In hypothyroidism, the clotting factors are degraded faster. So again, it will increase the warfarin effect. Newborn, they have a low level of the cortical clotting factors. So again, the warfarin effect will be increased. Factors decreasing the effect pregnancy, high plasma levels of the clotting factors. So plasma levels of clotting factor is more, so the reduced warfarin effect will be there. Nephrotic syndrome, drug bound to plasma protein is lost in the urine. In nephrotic syndrome, what happens is the drug which is bound to plasma protein, that is warfarin, which is bound to plasma protein, it is lost in the urine. So the effect will be reduced. Genetic warfarin resistance affinity to reductase enzyme is low. What is the genetic warfarin resistance? The affinity to reductase enzyme, that is a vitamin K epoxide reductase enzyme, is low in some individuals. So the warfarin will not act. They have a warfarin resistance in them. So that will lead to decreased effect of the warfarin. Adverse effects, its adverse effects are it can cause the hemorrhage. It can cause the bleeding. And the major factors that may influence bleeding risk are intensity of anticoagulation, concomitant clinical disorders, concomitant use of other medications. Now, clinical features will be, and any bleeding disorder is there, or other medications like antiplatelet drugs we are using, or fibrinolytic drugs are using. So that can increase the risk of the bleeding. Now, its clinical features will be there can be ecchymosis, there can be blood in urine, there can be GI bleed, there can be intracranial or internal bleed, which may be fatal. So, treatment of the treatment of bleeding due to warfarin, how we treat it is we can give the fresh frozen blood, fresh frozen plasma, fresh blood to replenish the clotting factors, and we can give the vitamin K, which acts as a specific antidote, but it takes 6 to 24 hours to resynthesize the clotting factors. We can give the vitamin K also, which acts as the antidote to warfarin anticoagulant, but it takes the 6 to 24 hours to replenish the or to resynthesize the clotting factors. Other side effects, it can cause loss of hair, it can cause diarrhea, it can cause dermatitis, it can cause skin necrosis. Skin necrosis are the patients who are on a deep vein thrombosis therapy or pulmonary embolism therapy of warfarin. So they may develop dermatitis or skin necrosis as the side effect. This is warfarin-induced skin necrosis. So contraindications are same as heparin, and we should not be used. It should not be used in pregnancy. Heparin was safe in pregnancy, but warfarin is not safe in pregnancy. It causes fetal warfarin syndrome in early pregnancy, in which there is hypoplasia, means the nose will be depressed or saddle nose will be there. Eye socket will be hypoplastic. Hand bones will be hypoplastic, or growth retardation can occur. If given later, can cause the CNS defects. In pregnancy, if it is given, it can cause the CNS defects, fetal hemorrhage, or fetal death can occur. And it can also cause the vitamin K deficiency. So vitamin K deficiency, we have to contraindicate it. So this is how the warfarin syndrome, fetal warfarin syndrome looks. There is a depressed nose, microcephaly, hypoplastic limbs, hand bones, and mental growth retardation. So interactions, broad spectrum, how the effect of the warfarin can be increased is when we give the enzyme inhibitors or when there is hypoprothrombinemia, like newest cephalosporins, when they're given along with this warfarin, there will be hypoprothrombinemia, means the prothrombin levels will be reduced, so clotting factors will be reduced. Sulfonamides, indomethacin and probenecid, they displace the warfarin. So displace the warfarin. So warfarin will increase in the blood and there will be enhanced action. Aspirin also, it is the antiplatelet. It also displaces the warfarin. So warfarin levels will increase in the body, leading to bleeding or enhanced effect. Broad spectrum antibiotics and liquid paraffin, they decrease the vitamin K. Now, various broad spectrum antibiotics and liquid paraffin, they decrease the vitamin K, so there will be enhanced action of the warfarin. Reduced action is by the microsomal enzyme inducers and OCPs in levels, increased levels of clotting factors. Oral contraceptive pills, they will increase the levels of the clotting factors and there will be reduced effect of the warfarin, and enzyme inducers will induce the uh, metabolism of warfarin, leading to reduced dose and reduced effect. So this is the difference between heparin and warfarin shown in the table. Now this heparin is a mucopolysaccharide and it is naturally available from the hog lung or pink intestine. Now it is the coumarin derivative warfarin and it is synthesized synthetically. It is obtained from the coumarin. Heparin is parenteral. It can be given IV or subcutaneously. Warfarin is oral. Heparin action is immediate, but the warfarin action is 1 to 3 days. It is delayed. Duration of action is 4 to 6 hours. Duration of action of warfarin is 3 to 6 days. Activity, it is active in both in vitro and in vivo media, but warfarin is active only in vivo media. How is the mechanism is? It will block the action of the factor 10 and thrombin, that is 2A. Factor 10A and factor 2A is inhibited. Here it inhibits the synthesis of the clotting factors, that is warfarin. Antagonist is protamine sulfate in heparin and vitamin K in warfarin. Variability in response is little in heparin and it is marked with warfarin. Lab control is seen by activated partial thromboplastin time or clotting time. And this warfarin lab control is seen by prothrombin time or international normalized ratio. Drug interactions are fewer with heparin, but many and significant with warfarin. It is used to initiate the therapy. It can be used in the treatment of deep vein thrombosis, in the acute myocardial infarction, in unstable angina, in pulmonary embolism, in transient ischemic strokes, in cerebral vascular disease. So, in all these conditions, we have to give the heparin to initiate the therapy, and for the maintenance, we can give the warfarin. So, next is the rivaroxaban, which is a which directly bind and inactivate the factor 10A, and it has a rapid and the short-lasting action. This factor 10A oral inhibitor is the rivaroxaban. It is oral, 10 milligram once daily dose is given. Oral bioavailability is 80%. No coagulation monitoring required. And it is approved for hip and knee replacement surgeries. And it started 6 to 10 hours after the surgery. Side effect is it can cause bleeding, nausea, hypertension, tachycardia. Now, oral direct thrombin inhibitor is the dabigatran atixylate. It is a prodrug which is hydrolyzed to dabigatran. It rapidly, reversibly blocks the catalytic site of the thrombin and it is given orally. And 150 to 220 milligram once daily can be given. Approved for the prevention of stroke in non-valvular arterial fibrillation. It can be used for the prevention of stroke in non-valvular atrial fibrillation. INR of monitoring not required. Side effects are bleeding and hepatobiliary disorders. Next oral direct thrombin inhibitor is the malagatron, rapidly metabolized to malagatron, a direct thrombin inhibitor, and onset of action is much faster, used in the prevention of the venous thromboembolism in major orthosurgery. 24 milligram daily twice for up to 11 days can be given. INR monitoring is not required. Malagatron is excreted primarily in the kidneys, so dose reduction may be necessary for patients with renal failure. So what are the uses of anticoagulants? These can be used in the deep vein thrombosis, pulmonary embolism, myocardial infarction, unstable angina, rheumatic heart disease, in which there is atrial fibrillation, in cerebrovascular disease, in vascular surgery, prosthetic heart valves, retinal vessel thrombosis, extracorporeal circulation, and hemodialysis. We can give this anticoagulants. Thank you. That's all with the oral anticoagulants. I hope you understood this video. And if you understood this video and if it is helpful to you, kindly subscribe to my YouTube channel. That is Dr. Nitika Pharmacology Discussion. Thank you. Be happy, be blessed. Stay safe. Happy learning. All the very best. Thank you.